I want to talk about clinical validation of contrast-enhanced ultrasound LI-RADS, which was just development of the LI-RADS for contrast-enhanced ultrasound was a huge achievement. And I think it was the first time the contrast-enhanced ultrasound got fully integrated in an ACR, or American College of Radiology, LI-RADS scheme. Have some disclosures here. So contrast-enhanced ultrasound LI-RADS is this standard system for technique, interpretation, and reporting of imaging findings in patients who are high risk for HCC. The problem with those patients is, especially in cirrhotic patients, lots of precursors of HCC, like dysplastic and regenerative nodules, can look similar to well-differentiated HCCs. Also, we really need to try to differentiate HCCs from non-hepatocellular malignancy, like cholangiocarcinomas or metastasis and whatnot. And without this system, we could detect lesions, we could see them, but our specificity was pretty poor. If you apply, you use some guidelines, the specificity was probably close to 75%, which was not obviously good enough to send those patients straight to treatment. But now with contrast-enhanced ultrasound LI-RADS that we developed in 2017, we now have very nice system to classify findings, and we drastically improved our specificity. LI-RADS, similar to contrast-enhanced ultrasound LI-RADS, similar to CT and MR LI-RADS, can only be applied at this point patients with high risk factors for HCC. Cirrhosis, hepatitis B, or current or prior history of HCC. We're not applying it to cirrhotic patients from other causes. We're not applying it to children at this point, but I think it will be very interesting to see how the system performs in other patient populations. Stephanie mentioned briefly about LI-RADS, but again, similar to all other RADS, like BI-RADS for breast or PI-RADS for prostate or lung RADS and whatnot, it will classify lesions in several different categories. LI-RADS NC is not characterizable lesion where you cannot make a diagnosis because of image degradation or omission. Tumor in vein, very unfortunately severe category that precludes patients from getting transplant or other treatments. LI-RADS 1 and 2, benign lesions. LI-RADS 1 is definitely benign. We know for sure this is benign. Cyst, hemangioma, focal fat, you name it. LI-RADS 2 is probably benign. We kind of think it's benign, but we're not 100% sure, and those patients usually go back for some additional imaging. The most important categories are here, LI-RADS 3, 4, and 5, and that's where contrast-enhanced ultrasound can really provide very precise differentiation between precursors of HCCs and actual hepatocellular carcinomas that are characterized as LI-RADS 5. Very interesting and very important category is LI-RADS M. Those are lesions that we feel are malignant. We just don't have enough diagnostic confidence to call them straight HCCs. And the reason why we want to have this category and we want those lesions which we don't know what they are to go into, because we will biopsy LI-RADS M lesions. LI-RADS 5s, they should go straight to treatment, TACE, Y90, ablation or whatnot, but if we're not sure, we want to have this LI-RADS M category to filter those lesions that are either suspicious or poorly differentiated tumors that need some additional tissue sampling. We created a diagnostic table to tell 3, 4, and 5 apart, and as Stephanie mentioned, for LI-RADS 5, we want to be very strict. This system was designed not to pick up every single HCC. Our sensitivity by design is quite poor. But what we want specificity. We want every single, or as close to every single LI-RADS 5 lesion to be HCC so they can go straight to treatment. We don't need to biopsy them. We don't need to follow them up. We don't need to do nothing. They can go and proceed with appropriate treatment. Right after we designed this system, we ran 2 retrospective studies. One was done by Stephanie's group in Canada and one by Fabio Piscaglia group in Bologna, and they have very high specificity. Sensitivity was a little bit different, but it reflects the dangers or drawbacks of retrospective studies because every hospital is different. They collect data in a different way. And when we did those retrospective studies, we didn't follow the protocol of image acquisition. And I think one of the most important achievements of LI-RADS group was designing a very standard and very rigid protocol of image acquisition with arterial phase enhancement, cine loops, and then intermittent imaging for up to 7 to 10 minutes. And by doing that, we can now look at data between different hospitals and between different institutions. So with that, it was very, very promising. But again, every time you talk to CT and MR people about contrast-enhanced ultrasound, they always ask you the same question. Have you validated this in multi-center prospective study? And the thing is, LI-RADS for CT and MR never been validated in multi-center study. They never had large studies to confirm the accuracy. It was all done in small, tiny centers using retrospective data. But for contrast-enhanced ultrasound, they wanted something done very, very inappropriate fashion, so to speak. So we said, okay, fine, we'll give you the study. So we did a study, and the aim was in prospective multi-center trial to validate contrast-enhanced ultrasound LI-RADS and determine the diagnostic performance of contrast-enhanced ultrasound for HCC detection. We went a little bit crazy, but I'm glad we did. We had 11 international centers, and the reason for that is we wanted to see performance of contrast-enhanced ultrasound not only at marquee contrast-enhanced ultrasound places, but we wanted to see how contrast-enhanced ultrasound performs at the smaller hospitals. We have a fantastic range of institutions in our study, and I'll show you in a second, ranging from Jefferson University, Calgary, University of Bologna to smaller hospitals. Our statisticians gave us a heart attack. They told us we need 640 patients to achieve appropriate power to our sample, and that's one of the reasons why we end up with 11 sites. We have very strict and very rigid protocol, and thanks God we have fantastic researchers working with us and very good research coordinators. So we were able to achieve all this rigorous patient selection, and we were able to get contrast-enhanced ultrasound and CT and MR performed on every single patient within 4 weeks of each other. So there is no delayed in diagnosis, and there is no risk into running into changes in appearance of the lesions as time goes on. Those are our sites. Again, some really well-known institutions in contrast-enhanced ultrasound arena. Some smaller places like Einstein Medical Center, they just started contrast-enhanced ultrasound practice weeks before we enrolled them in the study. Swedish Medical Center and Vanderbilt University also had very, very kind of young clinical contrast-enhanced ultrasound practices. So it was very interesting to see how those guys will compare to Stephanie's or Fabio's or Paul Sidu's places. Study protocol was a little bit tricky, and it took us some time to kind of nail it down and also to communicate it appropriately. But fortunately, again, because we have fantastic collaborators, everybody was able to follow it. So we draw patients with two groups. Patients who would get ultrasound as a screening for HCC because of their high risk factors, or patients who got CT and MR first for whatever reason. In some places in America, like in Texas, for example, some places in California, they do CT and MR to screen for HCCs in high risk patients. So we would draw patients from there. They would get focal liver observation, obviously untreated. So if we have just screening ultrasound, they will go to get contrast and the CT and MR for further characterization. And then if they get CT and MR first, we will trickle it down and get contrast-enhanced ultrasound performed. So after we get that, within 4 weeks, we would send them to CT and MR for LI-RADS classification. And from there, we would split patients based on CT and MR classification. 1 and 2s will be considered benign, and they would achieve final diagnosis. From there, LI-RADS 5 lesions on CT and MR will be considered HCCs, and LI-RADS M lesions will go to biopsy. LI-RADS 3 and LI-RADS 4 are troubled child, so to speak, of liver imaging. Nobody really knows what to do with them, and we send all those patients to multidisciplinary discussions. We would get hepatologists, cancer surgeons, transplant people, imagers in the same room, and we'll decide what to do. Majority of them would go to follow-up imaging, and then we'd do this classification again, and we would trickle down patients until we can achieve some kind of final diagnosis. Unfortunately, some of the LIRADS 4 lesions that remain LIRADS 4 for over a year, we had to exclude them because we cannot physically achieve final diagnosis on those patients. But majority of patients will either get tissue diagnosis, definite LIRADS 5 categorization on MRI, or being 1 or 2 to be classified as benign. We stopped enrollment in this study probably 2 weeks ago after 4 years of active enrollment, and I'm very happy to tell you that we successfully recruited 648 patients with HCCs, and they have, with the risk factors for HCC, and they combined have 707 nodules. So we went a little bit over with patient recruitment, thanks God, but some of those patients would be removed from the study, and I'll show you why. All right, so this is very preliminary data. I really analyzed this 2 days ago. It's not entirely coherent because some of the charts are incomplete. We're still waiting for some confirmations, and probably 100 patients still in imaging follow-up or getting some data collected. But in general, we have male predominant patient population. Vast majority of our patients in our study are patients with cirrhosis. This is typical for North America and Europe. All those patients with HCC, unlike Asia, where a majority of patients will have hepatitis B, they present with cirrhosis. So these study results will probably be applied best to North American and European population. Liver disease etiology, majority have alcohol or hepatitis C cirrhosis. Very few patients with hepatitis B, only probably 10% or so. But still, we have pretty good distribution, and we're not married to just one liver disease etiology, which is very, very good. LIRADS classification on the initial imaging was quite dispersed and diverse. You can see that LIRADS 5 lesions only composed of 42%. So we have really wide distribution of different LIRADS categories in our group, which is, again, very, very good and interesting because you don't want to stuck with vast majority of your patients being confined to just one LIRADS classification. Initial CT and MR was also very interesting. It was majority of them were LIRADS 5s because incidence of HCC in our high-risk population is so high. But also MR was not absolutely, or CT was not absolutely slam dunk. LIRADS 5s, we have quite a distribution of the cases in those patients as well. What was very interesting to see on these early slides is that LIRADS NC, non-characterizable lesion on contrast-enhanced ultrasound in our patient population, we saw this in about 5% of patients. Very large patients, or when we cannot see lesion on contrast-enhanced ultrasound, or there was something wrong with the IV or whatnot, 4.8%. Take a look at MRI, 6.1. So every time my CT and MR colleagues tell me that CT and MR is more reliable technique, I just pull them this slide and tell them actually not so much, because we can see more and we can characterize more lesions on contrast-enhanced ultrasound compared to CT and MRI. Large number of patients went into follow-up imaging because, as I showed you before, quite a few patients had other than LIRADS 5 or 1 or 2 categories on CT and MR. So probably a third of our patients, 31.7%, went into follow-up imaging, and we are still sending lovely emails to our sites asking for imaging follow-up results, but we're almost there. I think in a couple of months we'll complete data acquisition and we can start running real statistics on our data set. Final diagnosis was achieved in majority of patients on initial CT and MR. LIRADS 5 lesions, so 1 or 2 on the initial CT and MR were characterized appropriately. And then you see 14% of patients, we went into follow-up CT and MR, and when the lesions turned into LIRADS 5, or they were downgraded to 1 and 2, we could achieve final diagnosis on them. Probably 23% of our patients got biopsy. Honestly, majority of patients in Europe with indeterminate findings would go straight to biopsy. In North America, we would tend to follow them up with imaging. Different practice parameters, but honestly, at Jefferson, we biopsy more and more lesions because things we find on those biopsies in patients that are slam dunk LiRADS 5 on MR is just mind-boggling. Combined tumors, cholangiocarcinomas, mets, you name it. So we biopsy more and more lesions. And a few patients went and get final diagnosis on explant histology. As a result, we have 63% of our, 63% of our patients have HCCs. Unfortunately, we lost 112 patients and we had to label them indeterminate. Patients who would get ablation right after contrast-enhanced ultrasound with indeterminate MRI, which happens at some of our larger hospitals where physicians would trust contrast-enhanced ultrasound more than they would trust CT and MR. And quite a few of those patients, especially when they're close to getting transplanted, the hepatologist will send them to ablation without achieving final diagnosis, which good for patients, but kind of messes up our statistics a little bit. Other malignancy was only 4%, usually cholangiocarcinomas, mets and whatnot, and 15% of our cases were benign. Not a huge number, but again, those are patients high risk for HCC. So they don't have hemangiomas, they don't have cysts as often as normal patients without risk factors. All right, results. So far, based on the data that I have as of yesterday, our specificity is 96.2%. Very, very good. It's as good as CT and MR, if not a little bit better. We did have 9 false positive results in our group, and we need to closely take a look at those things when we have all the data combined together. 4 benign lesions were classified as LiRADS 5. I think 2 liver abscesses and 2 dysplastic nodules. Interestingly, in those patients, MRI was all over the place. 1, 3, 4, and LiRADS 5 on MRI in benign lesions that were LiRADS 5 on contrast-enhanced ultrasound. 5 cases of other malignancy, cholangiocarcinomas, combined tumors. Again, MR was also all over the place. Honestly, missing these 5 lesions with other malignancy, I need to look at the data, but if they're small cholangiocarcinomas or small cholangiohepatomas, it will not negatively affect patient treatment, because if they go into ablation or they go into some kind of local regional therapies, outcomes of those lesions are the same. So more to come. Again, I don't know much about those things. I need to get some more information. Sensitivity of LiRADS 5 is only 59%, but again, it's by design. That's how we designed the study. That's how we designed LiRADS. We don't want to pick up every single HCC. We want to be absolutely sure that what we call LiRADS 5 is HCC. So honestly, I think pretty good results, and more to come after we complete our data analysis. And this is by far the most important slide, I think. It presents malignancy prevalence per LiRADS category. Fantastic thing about contrast-enhanced ultrasound is in LiRADS 1 category, we had 0 HCCs. Meaning if we're sure that lesion that we're looking at is benign, it is benign. You don't need to do nothing with this. It is benign. You can stop it and tell patient that they don't have cancer. Similar to MRI, which is very, very good. LiRADS 2, we had 1 flash-filling hemangioma that was diagnosed as LiRADS 5 lesion because it had arterial phase hyperenhancement as flash-filling hemangiomas would, and then there was a very late mild washout. Again, this just happened. We have 1 out of 5 turned out to be cancer, pretty much the same with MRI. And LiRADS 3 is 42% of malignancy, LiRADS 4, 86, and with LiRADS 5 group, we have 98% of malignancy. And I'll show you a slide about HCC next. LiRADS M, very good. 93% of those lesions are malignant. So again, once you see LiRADS M, it's probably bad actor, poorly differentiated HCCs, cholangiocarcinomas. And we really want to send all of them to biopsy because our hepatologists now need to know molecular composition of those tumors. They need to know what chemotherapy to treat, what prognosis is. So honestly, I'm kind of happy to maybe label even more lesions as LIRADS M's and send them to biopsies because we need more information on them. And this is a slide that shows HCC prevalence per group. LIRADS 1, again, 0. This was HCC that showed up as flash-filling hemangioma, quote-unquote, on contrast-enhanced ultrasound. And 96% of all HCCs, of all LIRADS 5 lesions, were HCCs. Slightly better than MRI with LIRADS 5, slightly better than MRI with LIRADS 4. And about half of those LIRADS M lesions that we diagnose on contrast-enhanced ultrasound turn out to be HCCs, slightly better than MRI. So as a conclusion, I think contrast-enhanced ultrasound LIRADS is fantastic achievement, and I want to thank all people who were involved in designing this. It is fully integrated in American College of Radiology LIRADS category characterization. It has fantastic specificity of 96%, very similar to MRI, and I think this confirms very high clinical value of contrast-enhanced ultrasound in diagnosis of HCC. Of course, you can't do a study like this alone, and I want to sincerely thank all my colleagues and friends at Thomas Jefferson University, Kristen and Corey, who are absolutely critical to success of this study. Kristen is our STAR research coordinator that is in charge of data collection and management. Corey, who's done imaging, and she collects imaging and produces the PowerPoints for us to do further analysis. Some research coordinators, Fleming and John, for their never-ending support of my crazy research activities. Jesse Simon, who is our hepatologist, and Denise White, who make sure we don't run out of money while doing this. Contrast-enhanced ultrasound LIRADS working group. Special thanks to Claude Serlin, who is in charge of the entire LIRADS for American College of Radiology, for being crazy enough to invite us to write contrast-enhanced ultrasound LIRADS back in 2016. Yuko Kono, who was a chair of this group while we developed, and I think huge kudos to Yuko for leading this effort, developing contrast-enhanced LIRADS. Stephanie, Fabio, you probably know most of those people. And a huge number of collaborators at the sites. I think by last count, we have almost 100 people working on this study, but those are the main PIs and main research coordinators from the sites. And with that, I want to thank you for your attention. And yeah, funding, we got some money from the NIH, and we want to thank Bracco for providing contrast agent for this great study. All right, that's all I have for you. Thank you.
Thank you, Andre. Keeping an eye on the time, I think we could take one or two questions from the floor. If anyone has questions, I'm sure there are a lot.
Yes, approximately how many LIRADS 3 and 4 end up with a biopsy? Percentage-wise, approximately.
I don't know. I can't tell. I need to look at the data, but not a lot.
Not a lot.
Not a
You
lot.
follow them up mostly?
Most of them will go into imaging follow-up.
And I didn't see any sclerosing hemangiomas there. You didn't find any on your studies?
I can't say because I don't know if those hemangiomas are sclerosing or not.
Okay, just because, I mean, they can also wash out.
Right,
Be
correct.
confusing, right?
Yeah, yeah,
Okay.
absolutely. And that's why we had one of the hemangiomas that was LIRADS 5 turned out to be hemangioma on MRI. So nothing is 100%, but as long as we know it happens.
Thank you.
Stephanie.
Andre, obviously I love this study. Thank you. Andre, I'd like you to comment on what success you think that we'll get from that study in terms of, we're obviously striving to have AASLD include us as
Right.
imaging modality for HCC and for follow-up and for all those
Correct.
things. What do you think?
Well, you guys leading efforts to include contrast-enhanced ultrasound in the cancer guidelines. I think the second we have this study published, we have to go to OPTN and ASLD and tell them to stop it and just include contrast-enhanced ultrasound in their guidelines. Well, you know, ASLD did include LIRADS of CT and MR in their guidelines. Now they're saying that all imaging, quote, CT and MR of liver have to be done according to LI-RADS guidelines. And they're saying that they don't have enough, quote unquote, data to support use of contrast-enhanced ultrasound. Complete nonsense, but I think after this study is published, we have to go to them and they'll have less things to complain about.
That's great.
One more question?
What was the average size of your lesions? Did your accuracy depend on lesion size? Then the other question I had is, in terms of the LRM category, after looking at your images, any other diagnostic clues besides the typical CEUS LI-RADS findings that you found to be helpful in teasing out those issues?
Right, that's all fantastic questions. I think size was about 2.5 centimeters, so pretty small, and which is good, that's what we want. One of the reasons we wanted to do this study is exactly that. We want to refine LI-RADS M. And I want to refine LI-RADS 3, and I want to make sure we don't call too many lesions LI-RADS 4. So all of this was done for this massive collection. We have our CRF, and unfortunately for the sites, is probably 200 and so data points per patient. So once we have all of these analyzed, we'll probably have some better answers. I'm not ready to discuss it yet, unfortunately.
Just one other question, I guess, if you could comment on the sensitivity in this high-risk population. Because basically, are we not telling people with LRAD 3 and 4 that they don't have anything wrong and sending them home?
No, absolutely not. When we have LRADS 3 and 4, we tell them there is something wrong. We don't know exactly what it is.
What it is. So, but a lot of those had malignancy at the time.
Yes,
you're
correct.
Saying that.
Correct. Same with CT and MR.
So
we are very, very aligned with CT and MR. CT and MR also cannot tell 3s and 4s from HCCs. Because, it's a process. I don't know if pathologists can, because it goes from dysplastic nodule to progressed HCC. We don't know how to tell them apart. So until we get enough diagnostic confidence that this is HCC, we would not do it. Another reason to send all those patients to multidisciplinary conference, because even with LI-RADS 4 lesions, if patient is on the edge of transplant, they will treat it. So I think it's a bridge to multidisciplinary discussions and just providing hepatologists with enough information for them to make a diagnosis. I really don't want radiologists to drive treatment, to drive management of the patients, but this brings us at the table and we can communicate better than with our flowery language before saying there is hyperenhancement and mild washout. They don't know what it is. Now with classifications, it's easier to talk to them because they know 1 to 5.
Okay.
Mike?
I had a very similar question. It looks like LI-RADS designed for specificity and it nailed it. And now that we know that, what can we change or do different to increase sensitivity?
I don't know yet.
I'm hoping that maybe you want to comment about quantifying some of these results.
Well, we have all data. We have DICOMs, we have senior loops, we have a vast amount of data, and we have biostatisticians eager to get their hands on the data. So we will talk. I'll have more. We're also partnering with Stanford University. We're going to be running some advanced, and already running on probably half of our data, some advanced image processing algorithms, radionomics, AI, blah, blah, blah. So there is probably 5 or 6 people at Stanford looking at the imaging results and trying to fish out additional features. Because again, this is what it is. I'm not happy with 5. I'm not happy with M yet. I want to be more specific to non-hepatocellular malignancy. We're not entirely happy with 3 and 4. We want to have some other imaging characteristics or parameters, you name it, to do a better job. But we have the data. We have large, vast amount of data. We will get there.
Very good. I think we need to move on. Thank you.
Thank you
so much.